I'm going to talk about using intraoperative OCT in anterior segment surgeries, apart from the corneal transplant cases, which have been shown so nicely by David. However, I still would like to remember you some cases that have been presented by me in other presentations some years ago, when I found it very useful in lamellar procedures, graft procedures, for example, in DALC. Is it or not an air bubble when you have such a dense corneal emphysema, or in DALC or DSEC or DMEC surgeries when you are not sure about complete descemet removal, or in DMEC you are not sure about the graft position, is it upside down or not. But you also found it useful in DSEC procedures, like in this case where I had an accidental folded graft, or even in PK procedures where you have the peripheral cornea opacities and you cannot see very well the angle, and you would like to check if the angle is open or not, if you still have synechia, and so on. But I'm not gonna stay on these cases, and I should go further on some other new cases, and I'm going to present them to you this evening. This is one of our new ORs in which we have Leica microscope hang in the ceiling. It is Leica 844, and we also have, as you see, the in-focus OCT machine. We have here a Constellation or Centurion, so several Phacoemulsification machines, and we have this Ingenuity 3D visualization system as well. With the Leica technology, we have experience since 2015, end of 2015, when we purchased in-focus intraoperative OCT. And at that time, we bought it for its potential help in lamellar transplant surgeries, DMEC, DSEC, DALC. But we soon noticed that it is helpful also in penetrating keratoplasty, as I just told you. And recently and later on, it was confirmed also to be very beneficial in other procedures, both in anterior and posterior surgeries, as I will show you soon, I hope. Today's cases are new clinical cases, new types of surgeries, cataract procedures, cornea case. I still have a cornea case, which I found quite interesting. Secondary IOL implantation or glaucoma cases, better say post-trabeculectomy cases. Let's start with the first case, standard phacoemulsification for, let's say, standard cataract. This is the way how the OR looks when I'm using the Ingenuity machine. So this is the OCT in front of me, a bit to the left-hand side, and the Ingenuity. I'm using the Phacoemulsification machine, the Leica 844 microscope, either with binoculars or with intraoperative OCT connected to the microscope and the Ingenuity system. And I am prepared to perform a standard phacoemulsification surgery. Here I'm using the binoculars of the microscope, and here I'm using the Ingenuity system. There are three visualization possibilities, either on the OCT screen itself, which is in front of the surgeon here, or you can have it in picture of the Ingenuity screen, and you can use them in either of the four corners of the Ingenuity screen, or you can split the Ingenuity screen in two, and half of it you have the surgery image, and on the other half of it you have the OCT image. Or you can use them both, like in this case. I have here the in-focus screen, and here I have one picture image. In terms of cataract surgery, to be honest, I don't notice too many advantages using it in standard cases for the surgical technique itself, but I'm sure it is useful, and I use it for teaching purposes, for scientific purposes. For example, you can watch the wound architecture, the phaco position, the fluctuations of the anterior chamber depth, the zonules behavior, the iris behavior, and so on. And I think it is also quite useful in special, or let's say complicated cases like this one, sorry. in mature cataract with no red reflex. In posterior polycataract, for sure, it is helpful because you don't always assess the depth and the thickness of the lens. In posterior capsule rupture, in zonular rupture, subluxated lens, small pupil, and also in IFIS syndrome, you can also watch the behavior not only of the zonules, but also of the iris, which is floppy. And this is a case of mature cataract with relatively small pupil, and I'm using the in-focus image in a picture-in-picture, bottom right corner of the Ingenuity screen. It helps me in visualizing the position of a posterior capsule. Let's go further. Let's go on to the second case. It is also a cataract surgery, but a complicated one. I'm talking about a 62 years old male with an advanced cataract, finger count, pre-op visual acuity, no other eye pathology. I had implant to use a standard chop phacoemulsification and PCIOL implantation, but at the very end of the procedure, when I attempted to hydrate the paracentesis, I saw a strange line, slightly curved, thin line, which I presumed it was a descendant membrane detachment. Accidental detachment, of course. I immediately asked for the in-focus OCT, and I had the confirmation. Indeed, the OCT showed me and helped me in assessing the detachment extent of the descendant membrane. And it also helped me in solving the complication by injecting air in the Anterior chamber, as you will soon see. So this is the surgery. I'm at the end of the surgery, and this is that tiny fine line highlighted by the red arrow, which I presumed it is a accidental descendant detachment, and indeed the in-focus confirmed me this incident. In 1/3 or almost 1/2 of the descendant, I injected air, but it was not enough. The in-focus helped me in showing me that it was not enough. I injected more, and at the end, I checked once again with the in-focus OCT, and indeed it was, at the end, I could see that it was really attached, completely attached. And this is the second case, complicated phacoemulsification as well. But in this case, I have patient with cataract on corneal transplant, penetrating graft done several years ago. The surgery went very well. It was done with help of the femtolaser technology. The lady was prepared to receive a toric IOL, which it happened. And at the end of surgery, I need to go a bit, it is a heavy, let's say a heavy video, so I really need to show it to you once again. When I attempt to hydrate the main incision, look here, you don't want to miss it. Look how this circular line, and I assumed it was accidental descendant detachment, and indeed the OCT showed me that it was almost, let's say, 90% of the descendant, it was detached. I solved the problem in a similar way, like I did in the previous case, by injecting air. And to the third day post-op, the cornea looked quite nice, a little bit of edema, and 3 descendant folds in which some blood from the main incision entered. 2 weeks post-op, the cornea was clear, no more edema, as you can see clinically on the anterior segment photography and on the anterior segment OCT. But there were still those 3 small folds in the descendant filled with blood, but with good vascular visual acuity. And 3 months post-op, the cornea looked perfect. So the graft, the penetrating graft, which was severely injured by my accidental descendant detachment at the end of the cataract procedure, this graft looked perfectly. The best corrective visual acuity was 0.9. We had a clear cornea, completely attached endothelium and descendant membrane, no other issues. Let's move on to the fourth case. It is an interesting corneal transplant case, a female, 62 years old female with a recent penetrating keratoplasty for dense corneal dystrophy. And we had an apparently standard and uncomplicated PK procedure. But in early post-PK days, we noticed an inflamed eye and lack of graft epithelialization, which should be done in a few days. At this point, we performed an anterior segment OCT, and we noticed an irregular folded line in the anterior chamber. You will see it soon. And we assumed it is a retained descemet membrane, which needed to be removed, of course. So our surgical plan was to use a surgical microscope attached with attached OCT. So this is Leica 844 with the attach and focus OCT. We are supposed to use color to identify the descemet detached in the anterior chamber. Of course, a lot of OVD, especially dispersive, to protect the cornea. You want to protect the endothelium of this fresh graft, recently performed penetrating keratoplasty, and you also want to protect the anterior capsule of the lens. And of course, we will gently extract the retained descemet under continuous intraoperative OCT control. You will see it was really very helpful in this case. And at the end, we're supposed to check the complete removal using, again, this intraoperative OCT. So this is the surgery. Let me run it for you. This is a dense corneal dystrophy. First day post-op, nice looking cornea, but failing to cover with epithelium. The OCT shows this membrane in the anterior chamber, and we need to enter again in this eye. We used OVD. We checked with the intraoperative OCT. You saw it is colored in blue because initially we inject blue vision, and now we extracted the biggest part of the descemet membrane. Again, a second larger part of the descemet membrane retained in the anterior chamber. All maneuvers must be very careful done. We checked with the OCT and we see it is remnant, so there is still some descemet remnant. Yes, look at it. It was covered in the angle, and again another one here. So now a final check showed us that we completely removed the retained membrane. A few days post re-intervention, a nice cornea, and this lady went very well after intervention. We had a quick epithelialization of the graft. This is the pre-op OCT, and bottom right, you see the post-re-intervention OCT with no membrane in the anterior chamber. 2 weeks post-op, the cornea looked very well, the graft looked very well. We had later, after half a year, best corrected visual acuity 0.7, but decreased unfortunately to 0.4 in the first after 1 year because she developed a cataract. But after cataract removal, the best corrected visual acuity was 0.8. So she is now a happy patient, and at 2 years, the anterior cell count is quite good, 1,800 with good morphology. No other issue in this eye. Let's go further to the 5th case. This is a male, 72 years old male with a rich eye history. In 2017, he had a failed cataract surgery in another clinic, finished by implantation of an anterior chamber IOL, bullous keratopathy, and secondary glaucoma. He came to us with a painful eye, very low visual acuity, hand movement, and high IOP. In 2018, after obtaining a lower IOP with medication, we proposed him for a combined procedure, anterior chamber IOL explantation, anterior vitrectomy, and penetrating keratoplasty. But we prefer to leave this patient aphakic because we were afraid of new rise in of the IOP, and also we didn't know the potential of this eye. And we said, first of all, we need to keep a low IOP and to have a quiet eye with no pain and a clear graft. And indeed, between 2019 and 2021, the visual acuity was satisfactory, 0.3 with plus 11 and a normal IOP. In 2022, he was supposed to receive posterior chamber IOL sutured sclera, but we noticed the drop of the visual acuity to 0.1. And we performed an retinal OCT, and we discovered an epiretinal membrane. So we took the decision to perform a combined procedure, secondary PCIOL, fixed at sclera, and the epiretinal removal. So that was the plan, to use the constellation for the posterior vitrectomy, to use the Ingenuity visualization system, as we always do in our posterior surgeries, and of course the Enfocus intraoperative OCT attached to the microscope. The surgery has been done by our colleague, Dr. Lucan Mishev. He uses 3 trocars of 23 gauges, and he removed the epiretinal membrane under blue dye, dual blue, in his and our standard procedure. And then he implanted the Carlevale IOL, fixed a sclera under scleral pockets, and we use the Enfocus OCT not only for checking the macula, but also for checking the position, the correct position of the haptics of this Carlevale IOL. So this is the lens. You can see it in the picture at the beginning of the video, and again we have busy slides, so allow me to enter in this way. Maybe it will function better indeed. Let me see if the things are going. Yes, sorry for that, but this is a heavy heavy slide. This is the eye at the beginning of the surgery. Now the RMA is completely, epiretinal membrane is completely removed. So now we are focusing, Lucan is focusing on the implantation of the Carlevale IOL. He already performed the 2 lateral scleral pockets, as you see. And because there are pockets and not flaps, he doesn't really see, the surgeon doesn't really see the position of the haptics. So that's why we found quite very useful using the OCT, intraoperative OCT, in checking the final position of the 2 haptics. Here on the left side haptic, and then you can see here under the flap, under the pocket, sorry, the very well and correct position of the haptic on the right hand side. And now we will finish with 2 cases, glaucoma patients. They both had already trabeculectomy procedure, but they had some complication post-trabeculectomy. First of all, we have 73 years old male patient with chronic open-angle glaucoma and trabeculectomy done 3 weeks before. Unfortunately, the IOP didn't get low as we expected and as we wanted to. It was 25, 28 with 2 local medical treatment and local massage. Because his CD ratio is 0.8, of course, the target pressure in this eye was much lower. And at anterior segment exam, we noticed an encapsulated bleb, which needed to be resolved one way or another. The other eye was an advanced glaucoma, so this was his best eye. Our plan is to use, again, Leica 844 surgical microscope, connected to which we have the Enfocus intraoperative OCT and the Ingenuity 3D visualization system. The intervention will be done under topical anesthesia with a standard needle with bent 25 gauge needle under scleral flap and under the conjunctiva, then a local message, and of course we will use the OCT to check the filtration through the bleb after needling. So this is the surgery. We use this bent needle. You can also see here the bent needle to enter under the flap and under the conjunctiva, so in 2 different planes. And this is how OCT is quite helpful, because it helps us in visualizing these 2 different planes, under the flap, between the flap, the scleral flap and the scleral bed, and on the scleral flap, between the scleral flap and the conjunctiva. And we see that it is flattened. We can also see on the microscope, but it is much better controlled here in the OCT. So we don't have anymore this cystic walls of the bleb, but we still have good drainage under the scleral flap. Look here. So again, it was very helpful in this case. The second case, a 64-year-old male patient, again with advanced glaucoma, with not satisfactory IOP post-trabeculectomy, and again we need to reoperate him for needling this time flat bleb, not cystic bleb, but flat bleb. And the OCT is again helpful in showing us where the three levels, the three planes are. First, we enter with a bent needle under the scleral flap, between the scleral flap and the scleral bed. You will see in a moment here better. And then we enter between the scleral flap and the conjunctiva or tenon. As a matter of fact, the tenon is still there and it's fibrotic. And here you can see how nice we have two different spaces between the three planes, the scleral bed, the scleral flap, and the conjunctiva and tenon. And by massage, we can nicely see a good drainage now after the needling of this flat bleb. Again, OCT is showing us so nicely the spaces created by our maneuver of needling. So let's have a conclusion. We have two Leica surgical microscopes, M844 and M820. We use them since 2001. Now we have a new clinic with brand new equipment, so 90% of it is quite very new, but we still keep and use these Leica microscopes. Why? Because we are very happy with them. They have a perfect contrast and color separation. They have an excellent coaxial illumination, providing stable and consistent red reflex, even in tilted eye. We also have a good depth of focus, especially in posterior segment surgeries, where it maintains the same focus and depth of field, even with high magnification. And not at least, we save space in the OR with a sailing mounted microscope. We have both of them are sailing mounted. So I hope you enjoyed our presentations. Thank you for being in front of the computers. Thank you.